Good evening, and thank you for the opportunity. And as we all know that cataract is really, extremely common in diabetic patients. It's much more common because it can develop rapidly and also at a younger age. And at any time, almost 1/4 of our cataract surgery patients, in fact, do have diabetes. And in order to optimize the outcome, the visual outcome of such patients, as we've already seen so many complications in their, diabetic patients with retinopathy, we need to give them special attention. So the indications of cataract surgery could be an advanced cataract where you have a poor visualization of the retina, where we need to monitor the diabetic retinopathy or give treatment. It could be a combined surgery with a VR surgery, or it could be also a patient with an associated glaucoma. So the main concerns that we're dealing with, as we know, is this post-op cystoid macular edema, which is much more common in diabetic patients as compared to normal patients. A worsening of the diabetic macular edema, which is already pre-existing. Such patients can also progress to PDR. There can be increased inflammation, or there could be a risk of infection in poorly controlled diabetics. And it is also a more challenging surgery, especially in patients who have already undergone a VR surgery or who've received several injections. Now, a comprehensive management is important preoperatively, certain intraoperative methods to reduce the inflammation and to improve the outcomes, and post-operative treatment. Now, preoperatively, as Dr. Dinesh Talwar had already said, a systemic control and evaluation is very important in such patients. And such patients, we need to see that their sugar is well controlled, HbA1c is well controlled, and also look at the lipid profile and other parameters. Here is another example of a patient who had diabetic macular edema, center involving, and with 1 year of good systemic control, you can see how beautifully the retina has cleared up, and such a patient is now suitable for going ahead for cataract surgery. If we had done it earlier, then we would not have got an optimal outcome. So as we know that the HbA1c should be controlled, Dr. Ajay already said that it should be less than 7%, but at the same time, we must, liaison with the diabetologist that it should be a gradual decrease, because a sudden reduction in the HbA1c has been shown to worsen the diabetic retinopathy. So a slow one, every month, maybe 0.5 to 1% reduction in HbA1c is good, but not a very rapid one. And such patients should be followed up very frequently for their fundus examination. So preoperatively in the anterior segment, the things that we really want to look at is these patients have more inflammation. And so starting them on pre-op NSAIDs 1 week preoperatively, whether Nepafenac, Bromfenac, or Ketorolac, such patients are also continued 4 to 8 weeks post-operatively, and that helps to reduce the inflammation and reduce the incidence of CME. Managing the ocular surface preoperatively, as we know, diabetic patients, their epithelium, cornea is not so healthy. They have hypoesthesia and many other problems. These things should be managed, and an unstable tear film can also give you very variable keratometric readings. So take a week or two to manage the ocular surface before taking them up for surgery. Again, do not miss looking at the iris, because such patients, if they have a mature cataract and you see that they have NVI, it does indicate the patient has PDR. And accordingly, you can prognosticate and manage the PDR first before going ahead for surgery. Glaucoma is often coexisting, and accordingly, we have to see whether we want to do a cataract surgery alone if the patient is only on one medication, or we want to plan out a combined surgery in cases where the patient is on maximum medical therapy. So the posterior segment management should always precede the anterior segment management, provided the visibility permits. However, if the patient, the clarity of the lens, if the patient has an advanced cataract, then obviously we have to go ahead for the cataract surgery and then manage the posterior segment subsequently. So depending upon the stage, we've already heard all the experts telling us the management for various grades of diabetic retinopathy. And here one would just like to say that patients who have little or no retinopathy, they can be suitable candidates for going ahead for an early cataract surgery. So patients with no diabetic retinopathy or mild to moderate NPDR, early surgery should be done. Whereas those patients who have maculopathy or PDR, first of all, refer them to your retina specialist. Let them manage the posterior segment first, optimize it, and then plan the cataract surgery. So intraoperatively, a few of the problems that we can face is poor pupil dilation and intraoperative miosis. Also, the endothelial dysfunction is there, so we need to take care of that. There may be associated zonular instability, especially in patients who've undergone multiple intravitreal injections, and the patients are often having advanced cataracts. So use a good viscoelastic to protect the endothelium. Be prepared with the pupillary expanders, CTR, capsular hooks, and we must always have a 3-piece lens as a backup just in case we have any instability in the zonules. So a careful biometry, especially in patients who've undergone VR surgery, one needs to look at that. And choosing a hydrophobic lens is always preferable. And here I would say that there are a lot of advanced technology lenses now available. And in patients who are well-controlled diabetics with little or no diabetic retinopathy, yes, after due counseling, you can go ahead for a multifocal lens. But patients with advanced diabetic retinopathy who are on injections or who may require a vitrectomy later, in such patients, a multifocal lens would definitely be a contraindication. Avoid using anterior chamber IOLs or iris fixated lenses. A scleral fixated lens would be preferable where you do not have adequate posterior capsular support. So just a few pearls that you may prefer to do it under anesthesia. You must have an optimal size rhexis so that the posterior segment can be visualized after surgery. Use a good viscoelastic to protect the endothelium. And in patients where you may have a posterior capsular defect, in patients who've undergone multiple injections and you find them having a posterior subcapsular cataract, in such cases, you may want to avoid a hydrodissection. And capsule polishing should be meticulous, and preferably the lens must be in the IOL bag to avoid inflammation, and remove all the viscoelastic to avoid a IOP spike in the post-op period. In case the patient is going in for a combined surgery, then you would like to suture the incision so that laser can be done post-operatively. And here I would like to specify that inflammation is, management of the inflammation is extremely important. So giving them aggressive topical steroids, NSAIDs in the post-op period, a regular checkup for glaucoma, and definitely a close follow-up with a retina consultant is important. In case of PCO,
sorry to interrupt. Kindly conclude in 2 minutes.
Yes.
Thank you.
So I would just end with that overall the visual outcome is very good with the advanced technique of phacoemulsification that we follow. And if we manage the comorbidities preoperatively, then the post-op results can be good.